It's difficult in Louisville, Kentucky, I can tell you, to find a primary care doctor. I had to search around for quite a while to do that. So for a big city like Louisville, that's a problem. You can imagine what it's like in other places. So anything I say about doctor shortages, and I'm going to talk only about surgeon stuff, really is not in any way to devalue or to demean any other specialty. In fact, I've got them in the family. My brother's an internist, and my daughter's an obstetrician. My daughter's now the hardest working person I know, certainly the hardest working in our family. And so we need all kinds of people. And most of my remarks will actually focus on general surgery. Can you hear in the back? Am I yelling loud enough? But all surgical disciplines, in my opinion, do have some issues. So I'm going to try to present some data, and you can data this to death if you like, on fact or fiction about whether or not we have a surgeon shortage, and I'll present a couple of anecdotal things and then some data. This is supposed to be, and my Google skills ran short on, there's a whole bunch of articles published on surgical shortages. What I was supposed to have was something from Wall Street Journal there, and the famous journal USA Today. I Googled last night surgeon shortage, and there were 841,000 citations under surgeon shortage when you Google it. So I think somebody thinks there's a surgeon shortage apparently. I have some data that I had accumulated in doing some of the workforce issues for the college, looking at hospitals and particularly search firms trying to find surgeons. Now they hold that stuff very closely, and what they'll tell you is this is what we're looking for. They don't ever really tell you much, even sometimes what state they're looking in. But we found over 1,000 hospitals in the country seeking general surgeons. That's probably about 20% of acute care hospitals. There are over 40 in Kentucky that I know of. And the average Kentucky recruiting time for a general surgeon is 3 years. So, I'm going to go through some data. Ohio State, UCLA, North Carolina, these are real places that have done, I think, some reasonable. Thank you so much. I've got to go to the UK game tonight, so it's really hard. I work in red country and I'm still blue because I grew up that way, but so I can't ruin my voice though. But at any rate, the general surgery shortage, estimated there's about 21,000 general surgeons, of which about 6,000 do very little surgery, if any. And remember the number I've got in red here: 705 die or retire annually. So the population that we have now is about 7.5 surgeons for 100,000. Now you can argue that that's good or bad, or and if you believe all that Harvard, excuse me, the Harvard lady, she's still here. But at any rate, if you believe the Dartmouth stuff, we might not need any surgeons. We annually train about 1,000 general surgeons, and I'll go through the breakdown of that in a minute. But if we're just going to keep up with our population, we're going to need to train 1,875 surgeons by 2020 just to keep where we are today. And basically, I can tell you there's no way we're going to do that. If you look at the fate of general surgery trainees, so we said 1,000 finish annually, about 50 to 100 of those, or 5 to 10%, actually never work. They get sick, they change careers, they sell real estate, they work for industry, they go into anesthesia, they quit. And women often quit, unfortunately, because of women, children, family issues. 60% now, and maybe that number's even a little higher, do additional training and focus on other surgical careers, transplant, heart surgery, and whatnot. The thing that this has done, and those things are certainly needed, those specialist people are needed, particularly if you need that kind of doctor. But it's created a huge void of generalists in almost all specialties. Whether that's an ENT, whether it's general orthopedics or whatever, it's a real problem. But the bottom line is that we have about 500 general surgeons entering practice annually, with about 705 needed to maintain the status quo, not counting where we're going with our increasing population. If, in point of fact, we get 44 million people walking around with a card in their hand, then one can, as is now being proposed, then one can wonder. And I'm not against the proposal, don't misunderstand, but we know from the passport data in Kentucky, as I understand it, that when people get a card, they use 4 times as much health care as they did before. And so some of that is going to go to surgical care. I have no idea, God help us, how we're going to do the primary care for that. But, you know, these are issues, and that's why I'm here to talk, I guess. In terms of the other surgical specialists, these are UCLA data. And what they projected, the way they did this study, is they looked at who's coming out to do surgical specialty care, how's our population going to grow, and the assumption was made, they looked through some things and said, these operations are probably going to get more common. Some of these things will, due to technology or other changes, perhaps get less common. Cardiac surgery, we know, is getting less common because of stent stuff and angioplasty and whatnot. But we're also now seeing the wave of angioplasty failures in 80-year-olds who are pretty bright and healthy otherwise. And what I've found from my 80-year-old relatives is if they're pretty bright and healthy, they ain't interested in dying just because they're 80. So it's a real problem. What we know in ophthalmology is that we're going to have about a 47% increase, mostly due to cataract surgery and aging. Cardiac surgery, we're going to have a huge catastrophe on our hands because we're not training. We're training almost no cardiac surgeons. General surgery, it's projected to have a 31% increase. Orthopedics and neurosurgery, because of joint problems, and in particular because of spine problems for neurosurgeons, and even otolaryngology, it's estimated are going to have about a 14% more need. Now one could argue, and critics, I think, of workforce things, particularly in surgery, have argued that, well, what you really have, doctor, is not a shortage, you just have a maldistribution. Well, that's not true, frankly. I mean, there is a maldistribution. I think that is true, but it's not the whole problem. Maldistribution, I think, is a major problem in that, in other words, it's, well, the rich people get care, the urban people get care, and whatnot. And one of the reasons I got interested in workforce issues is I still have a lot of family that lives in rural Kentucky, and that's been an interest to me. Almost the only oversupply that we have now is in plastic surgeons. And boy, since the recession, have they been an oversupply. It's been sort of interesting to watch. A lot of plastic surgeons are coming back to being real surgeons, and I hope I don't offend any plastic surgeons in the audience, but it's true. General surgery, though, those needs are present in most cities, big or small, and ED coverage for surgical care is a huge problem in virtually every city in the United States of America. A huge, huge problem. And I had, for another talk I was giving not long ago, because the trauma people, when I've done a lot in my life, get all exercised because of, you know, well, we're the only ones that have to do all this stuff, and we have all this stuff, and how bad it is for those people, of which I am one. I called around to see how long it would take you to get an appointment with a foot surgeon because my wife needed one, and I just couldn't get one, basically. And if I can't get one, you can imagine how the average person might have trouble. It's 2 to 3 months because there's only 2 or 3 of them in Louisville, and feet problems are huge problems with our aging population, especially with obese aging population. They kept talking about obese in the last panel, and I kept having to leave. I was so guilty. But spine surgeons, it's the same issue, some of the same problems, 1 to 2 months, and in a lot of the busy general surgeons, it's a matter of some weeks. In 1981, and I don't want to bore you with statistics, but these are, just get the big picture. 1981, 1,000 counties in the U.S., over a third of the counties in the U.S. had no practicing surgeon. By 2006, 303 had gained a surgeon, but 203 had lost all their surgeons. So, you know, but didn't, you know, a little bit of a net. There are now 925 counties with no surgeons in this country, with a population of nearly 15 million. Nearly 15 million. 60% of all the urban areas in the United States have a declining number of surgeons, and particularly a declining number of general surgeons. It's a problem. There's a lot of misperceptions about shortages. I am amazed at my colleagues in academic medicine who, you know, ivory tower kinds of people, I think, who, and I say health policy and politicians, knowing there might be some of each here, who do not understand the fundamental nature of where shortages occur. And I hear people say, well, that's rural, but rural is almost like it's wilderness, like it's frontier Alaska or someplace, as opposed to where people in America really live. In point of fact, towns of about 10 to 25,000 really is where most of the health care in this country are really delivered. My hometown of Moorhead is a medical center for, is it 5 or 6 counties? It's 5, isn't it? Or is it 5 or 6? And so, and there's no other hospital there. I mean, that's who's going to take care of the patient. So it may be 10, 12, 15,000, whatever Moorhead is now, but its catchment area is more like 65 or 70,000, which gets to be a pretty good sized place. So what's happened is that basically what hospitals do is they steal from each other. And so Moorhead, I learned yesterday, is lost now, or losing 2 new surgeons that we trained, who are wonderful young people, one of whom is from Moorhead. And he's going to go to Valparaiso, Indiana. It's not a bad spot. They got a lot of people up there. It's not wilderness. That's up by Purdue. And then the one that you'd recruited, I think, before that is going to Chillicothe. So you spend years recruiting somebody. They stay, and then somebody else buys them by offering him something different, more money, more, better, whatever. So this is a thing that is sort of hard to see, I know, but the green on here, and there's a few splotches of green, are where you've had significant increases in surgeons, and the sort of the lighter green kind of shade, and the beige is where you're sort of, the counties are holding their own, and then the white and other things is where there's just nobody, and you're losing. So if you look at that map, there's a whole lot of white where there's nobody. And you can say some of that's in Utah maybe, and some of that's out there in Nevada, and sure, there's that. And then those intermountain ranges where there's not a lot of people. But Kentucky's got a lot of white, and frankly, there are big patches of white all over the southeast. New York and the northeast much less so. And then there's spots where, you know, people have retired to Maine and are practicing some surgery now, and actually Maine's actually doing better. But the point is that they're what I call, or it's been called, surgical deserts, where you really just have whole big islands where there are no surgeons. Let me go through it for a moment, and this is where I might offend somebody. I don't mean to, but these are my views. It's not anybody else's. Of some of the causes of surgeon shortage in the country. First of all, as I've said, there is a shortage of all physicians. There have been some bad projections. There's been some, in my opinion, some devaluations of surgery as a discipline. I'll mention that. Public policy mistakes, I think. Some economic issues, which are huge, and some lifestyle issues, which are also huge. So, in my opinion, as I stated at the outset, many things exist. It's hard to find a primary care doctor, and God knows we need them. We absolutely must have them. And for my daughter, most of the people, my daughter's friends, think she's nuts. She's a smart, bright, do anything in the world, and she loves to deliver babies. And she says she's got the best practice in the world. She works primarily in Oldham County, Kentucky, if any of you know LaGrange, which is a suburb of Louisville, or adjacent county. She says, I've got the people that own the horse farms and the people that work on them. 20% of her patients are Hispanic. And, you know, she loves her practice, but you do have to be sort of crazy to want to do this kind of thing, you know, and to want to work all night and all. And she's on this weekend. Her call started this morning, and it'll end at 8 a.m. Monday morning. You've got to be nuts to do that in a way. But I think there's been an evaluation of surgeons and what we do, of the proceduralist. I don't know how many of you in the audience know about this whole cognitive versus the proceduralist or the technician kind of argument. It implies in its nature that surgeons can't think and don't. You know, well, you're not cognitive. You know, it's just monkey see, monkey do. And so there's the surgeon as technician view, which is ingrained in people from the moment they hit medical school, in my opinion. There's been medical school after medical school formed in this country to create primary care doctors. And while I think that's a laudable goal, as I mentioned, I'm not aware of any that have ever have anything to say about creating surgeons or even implying that surgery might have some value as a discipline. In our admission committee, and Dr. Adams and I were actually on the admission committee for many years together, and we always like to argue at times with each other and supported each other at other times. But now the admissions committee in Louisville, if you just lie or swear or whatever, you have to sign in blood, I don't know what you have to do, and say that you're interested in primary care, you get 10 extra points. If you say you're interested in heart surgery, you've got no shot. There's a big focus on procedures as cost drivers. And in point of fact, I think as was pointed out in the last panel, what's driving costs are diabetes and chronic illnesses. Surgical care is flat. It's flat as an actual number in terms of its percentage, while we're taking care of more and more patients. So, but people don't talk much about chronic care, and everybody talks about the procedures. And meaning no disrespect to our president, I'm a huge respecter of the office of the presidency. But the notion that somebody does a tonsillectomy for money, and the notion, as he stated, that you get $50,000 for doing an amputation, when in point of fact you get $200, is really ridiculous. I mean, it's a demeaning thing to those of us who practice surgery, and it really was very hurtful to me. I just got personally hurt about it that your president, would want to sort of call you out that way. And I think there's a lot of stereotypical images. You'd have to be old as me to remember old kindly Dr. Welby, who knew everything, and then Dr. Kildare, young Dr. Kildare was a neurosurgeon, chief resident, arrogant, brash, in your face kind of. So, and some of that stereotype is deserved, I admit it. But so I think we get painted with a black brush in many ways that perhaps we shouldn't. In terms of public policy, I could go on all day about that, but I'll mention just one. The Balanced Budget Act, I think, was that 1998? Was that when it was? I think so. It capped surgical residency positions there, capped it. And so we have huge numbers of unfilled primary care spots. We can take in everybody from India, and we couldn't fill them all. I'm exaggerating there, but it's close. And so it is a very, very hard to grow programs. In fact, you can't, because it's got to, it comes out of somebody's hide because the number of things have been capped. So that's been a real problem. And in all the proposed health care legislation, those caps are in fact remaining in all the proposals of the bill that I've seen. And I've actually spent a fair bit of time in Washington representing the college on some of those issues. I will say in terms of workforce projections, they've all been wrong. In terms of the number of surgeons that we were going to need and the number that we had, they've all been wrong. And so my only point there is one can question, and there are people who question some of the motives of some of the people doing the studies. I just say it's difficult to predict the future, and I would reiterate some of the earlier points. Be careful what you wish for in some of these things. In economics, you can't leave economics out of this in terms of why people are not terribly interested in going into surgery. In a budget-neutral world, the increase paid to primary care and radiology, it's not that those doctors are getting rich, but it's that the amount of money spent on those disciplines have really been going up. So surgeon incomes have plummeted, and some of that probably the readjustment was needed, but boy, it's kept on going. If you think about, you might spend more to get your sink unplugged if it's on a weekend than you would get paid to do a laparoscopic appendectomy, which is these are our numbers, $525. Laparoscopic cholecystectomy, $600. Open cholecystectomy, only $518. So when I went into practice in Louisville, that number is over $700. So now it's $518, and that's not an inflation-adjusted number. That's real dollars at a time when malpractice and practice expenses and everything else has gone up and up. Lifestyle, am I running over? All right. Lifestyle, I was worried. Average medical school debt's now about $125,000, and so the longer that people have to train to be good at what they do, to be good at their craft. And if I want somebody to operate on me, with all due respect, I ain't going to India, frankly. And we're now training our average general surgeon 6.4 years, general surgeon. If you're going to be a heart surgeon, it's another 3 years on top of that. And we're trying to shorten up some training and whatnot, but now our average surgeon, if they come straight through, is about 34. If they don't come straight through, they're ready for Medicare by the time they're ready to practice. It's an incredibly rigorous training. It requires time to develop master skills. If you're going to be a master concert violinist, it takes you 5,000 to 10,000 hours. Date on that are pretty good. If you're going to fly a jet and do it well, it takes you about 5,000 to 6,000 hours. And now jets can do simulators. I hear all this simulator crap. But simulators aren't patients either. And so a lot of this is just hard kind of grunt work and all. I work 60 to 100 hours every week of my career unless I'm doing something special and all. And I have at age 64 now got myself down to 60. I will tell you the new generation are not interested in doing that. They're certainly not going to do that without appropriate consultation. And that's especially tough. And this is where the problem really is that there's some people who can opt out. You know, if you're going to do thyroid surgery, for example, that's elective. I'm not aware of any emergency thyroid operation. Can't think of one. And all. If you're going to do small bowel obstruction, bleeding, ruptured stuff, trauma, that's 24/7, 365, no day off, no time. You don't get to pick, you don't get to choose, and neither does your patient, as was pointed out. So if we're going to have, I think, a surgical system that meets societal needs, that's got to be met, and it's got to be to some degree, I think, where the patients are. Let me talk about 3 consequences of shortage. One is access and distribution, impact on critical access hospitals, and then finally, in sort of dramatic fashion, people will die, you know, yikes. So, but it's true, and I'll show you data. Access and distribution, as the shortage worsens, there's going to be increasing raiding by wealthy hospitals of rural, less affluent public hospitals, inner city hospitals, the kind of place where I do a lot of my work every day. My hometown of Moorhead that I just mentioned, that's been now raided yet again. And that's not a bad place to work. I know a bit about their deal. I think it's not a bad deal for them, but whatever. There are already huge pressures on those who provide emergency care. So what sane, rational person is going to do that in something that doesn't reward your work commensurate to the way that others are being rewarded? There will always be a few people with altruistic, eleemosynary kinds of thoughts and ideas. Always will. And I mean, believe me, I could have made a lot more money in private practice, but I chose to do things differently in my life. I have no regrets for that and all. But the world is different. And we have created these surgical deserts. Who's going to go to the desert? Who's going to be there for patients where right now there is an undersupply of surgeons? Critical access hospitals, I think I looked at July 2009, there are 1,300 of those. It's virtually impossible for these hospitals to survive without a surgeon. Surgeons are the economic drivers for virtually all hospitals, small and large. But small hospitals, particularly if you've only got 1 or 2 people, they retire, they leave, they die, they become disabled, that hospital is immediately at risk. And the economic impact of a surgeon loss to a small town that then loses its hospital is incredible. You can't get industry if you don't have a hospital. You can't get teachers or keep them if you don't have a hospital. And it's a system that we must have, and we must have surgeons and doctors of all type to do that. In terms of impact on mortality, a surgeon can save lives. Now, we don't do that a lot. I actually, because I've done a lot of trauma, I've actually saved a lot of lives. I mean, just really have. But most of us don't. And the patients will say, boy, you saved my life, and I pat them and say thank you. But generally what I've done is you've just been confident and think you've done the right thing. Neurosurgeons with a subdural or subarachnoid hematoma or a subdural hematoma, epidural, I'll get it in a minute. With an epidural hematoma, that's a life-saving thing if you fix that. Somebody can do a tracheostomy for airway compromise, or somebody that can stop bleeding, or fix a ruptured aneurysm, or take care of somebody that's been in a bad car wreck. Boy, that's life-saving stuff. Now, I love my internist. He's a wonderful young man, and he may slowly save my life, slowly, incrementally, you know, with all that stuff he makes me do. He had got me to lose weight. I've never smoked. But if I'm dying fast, I'm a goner in his hands. I mean, he can't help me. He's just a great guy, but I'm just dead meat. Now, PCPs, again, meaning no disrespect, can get a lot of help through nurse practitioners, PAs, physician extenders. You cannot do that doing surgery. Even simple stuff you know, it's there, it's in your hand. And frankly, simple as the operations done on others, as we'd say. Here's some data I just want to show, and basically, I'll make this simple. Big blue dots, or blue means there's a lot of surgeons. The bluer the dot, or the bigger the dot, the more there are. So you see the Northeast, you know, New York City and New Jersey, boy, they're thick. Southern California, San Diego, look at that big dot over San Diego. LA, you can see Seattle, Chicago, Madison, Wisconsin, Minnesota, or I think that's Minneapolis, I gather. And then South Florida, boy, that's blue. A little bit of blue in Kentucky. We just get little blue dots in Kentucky other than Louisville and Lexington. You want to guess what brown is on this dot, on this map? Dead people. This is trauma. This is mortality rate. These numbers are big difference between the white, you know, the light, which is good. You know, so if you see where blue is, you don't see as much brown around blue. You know, so what that means is that surgeons actually do some good about keeping people from dying of surgical problems. And this particularly focuses on trauma. Here's Kentucky. See Louisville, see Lexington, see Cincinnati, northern Kentucky. And then you see, you know, Ashland. And even Ashland didn't do as much as we'd hope. I don't know who's from Ashland, but at any rate, so, you know, it's whiter around Lexington and northern Kentucky and down around Owensboro and Evansville. But boy, look at that dark brown in eastern Kentucky. And so, you know, unless you want to have dead people, you're going to have surgeons in eastern Kentucky. Solutions? I told you I had none. Here's what people talk about: insourcing, training more surgeons, and regionalization of care. Insourcing basically is a polite way to say we're stealing from other countries. And so what we're doing is we rely on the poorest countries in the world, or some of them, to furnish surgeons for the world's richest country. India, Pakistan, and Philippines are the three primary sources of international medical graduates who work in this country. And their training, I will tell you, is very, very different than ours. I'm not saying you can't train good surgeons in those places, but particularly in India, the quality of surgical training is incredibly varied. I mean, it's a huge population. There are about 10,000 medical schools. There are about 1,000. I mean, they got a bunch of they got more medical students. Never mind. So at any rate, so a lot of people come to this country and train, and that's good. That's been a huge source of workforce for this country. But the notion that we're going to import fully trained surgeons into our system, that is not a workable solution. And then there are also, in many places, considerable social, cultural, and language barriers, which we also have to overcome. In terms of increasing output, even if public policy changes and more positions are approved, there are several problems. There's a long lag time to turn people out. If we started today, it still would be 8 years or so before we get the first graduate out, probably, or 7 years. It's difficult to identify candidates now in medical schools where half are women, and again, I've already said, my daughter works harder than anybody I know, but her big frustration is that most women that she wants to hire to work with her don't want to work that hard. They're not interested in surgery as men are statistically, for good reasons. Lifestyle desires are different now from both sexes, and will they go to the desert? And then finally, people talk about regionalization. There's a lot of referral of surgical cases to centers now. That's not a bad thing. And particularly for complex care, I think it's a good thing. But it does not work well for emergencies. It simply doesn't. The time lag often to get people to where they need to go is too big a problem. And then I think one should ask a fundamental question, is do patients have a right to surgical care close to home, at least at some modest kind of level? Does it mean if you live in a small town that de facto you're going to have to drive to a big town to even be evaluated for right lower quadrant pain that might be appendicitis, by a surgeon? So, in summary, I've tried to present some anecdotal and real evidence that I think we do have a problem with surgical shortage. I think it's a really huge problem. We were sort of hoping, and I'll use my college hat now, American College of Surgeons, that perhaps there might be some focus on on these issues and workforce issues with some of the new talk of legislation. That has not come to bear to any significant degree. It certainly, I think, has multifactorial causation. I think there are some potential adverse consequences to a lot of the things we face, just as there are with all doctor shortages. And I see very few short-term fixes. And I think it's a huge problem as we have an aging population. And the only thing I always remind people, anytime I'm giving a talk like this, I've never given one quite like this, remember you're all pre-op. You know, statistically, 20% of you in this room, I actually probably looking around the room, it's going to be a little higher because I see a few gray hairs out there, but and I'm gray myself. 25% of you will have an operation in the next year. 50% of you will have an operation in the next 3 years of some sort. You know, it's just it. Thank you all very much.